Welcome to this explainer. Today, we're embarking on a real comprehensive journey into vascular access. So whether you're here to refine those everyday clinical skills or you're looking to build up some advanced critical thinking, you are exactly in the right place. Think of this as your masterclass. We're going to take those foundational things we do right at the bedside every single day and connect them to the big systemic rules that dictate why we actually do them. All right, let's build your practice to that advanced level. Here's a quick look at the syllabus for our time together today. We'll start off with device maintenance and assessments, then move right into critical thinking and practice, followed by research and quality improvement. After that, we'll tackle professional ethics and principles, and finally, we'll wrap up with legal and regulatory considerations. Okay, let's jump right in. Section 1, device maintenance and assessment. Now let's talk about the absolute strict mechanics of flushing and locking a device. Look, I know this sounds like a basic routine, but it's really a precise clinical protocol. Step 1, you absolutely must disinfect that needleless connector or injection port with a good friction scrub using alcohol or chlorhexidine for literally no less than 5 seconds. Now, why 5 seconds? Well, because that mechanical friction is exactly what breaks down those dangerous biofilms. We can't skip that. Then, you gotta let it dry completely. Okay, step 2, always verify blood return to assess patency. Step 3, flush it out with 0.9% preservative-free sodium chloride. But listen up, here is the golden rule, step 4. Never, ever flush against resistance. Seriously, if you feel resistance, just stop. Pushing through is not going to clear the line. It's going to cause a catastrophic catheter rupture or internal vein damage. Instead, you've got to take a step back and evaluate for kinks, improper connections, or internal occlusions. Moving on to dressings, the standard of care dictates that a transparent, semi-permeable membrane, your standard TSM dressing, has to be changed at least every 7 days. But, and this is a big but, if that dressing ever becomes non-adherent, wet, loose, or visibly soiled, like if it's pulling away from the skin even a little bit, it must be changed immediately. You gotta stay ahead of infections. Now, if you're using a gauze dressing, that timeline shrinks way down to at least every 2 days. And I really wanna highlight a highly specific precaution right here for our pediatric clinicians. If you're working with premature infants or kids under 2 months of age, chlorhexidine must be used with extreme caution as a skin antiseptic. The risk of severe skin reactions in those tiny patients is just too high. All right, moving forward. Section 2, critical thinking in practice. To really understand clinical data, you need to speak the same language as epidemiologists and researchers. So let's break down 2 terms that honestly trip people up all the time: incidence versus prevalence. Incidence refers strictly to the occurrence of new cases of a disease or injury over a specified period. Think of it like the number of brand new central line infections that pop up in your hospital in 1 year. Prevalence, on the flip side, is the total number of cases, so that's both old and new, present at a specific point in time. Let's say 10% of all the patients sitting in your ICU have a positive blood culture right at this exact moment. That is your prevalence. Just remember, incidence is the new arrivals, while prevalence is the total current burden. Now, as an advanced clinician, you're going to be evaluating literature constantly to guide your care, so you need to know the difference here. Qualitative research is deeply subjective. Think words, feelings, and experiences. It explores human phenomenons. Like, say, interviewing pediatric nurses about their emotional experiences when caring for critically ill children, and looking for recurring themes in a small group. Quantitative research, however, is purely objective. Think numbers, hard data, and statistics. It looks at cause and effect, it's super outcome focused, and it uses statistical methods. So if you're comparing 2 different skin prep procedures to see which one mathematically results in fewer infections, boom, you are squarely in the quantitative realm. Okay, let's shift gears a bit. Section 3, research and quality improvement. We all know evidence-based practice is the absolute gold standard of care, right? It's that sweet spot where the best available research actually meets your clinical expertise and your patient's preferences. But how do you actually find that research efficiently without pulling your hair out? Well, you use the PICOT format. This structured framework stands for P for patient population, I for intervention, C for comparison, O for outcome, and T for time. By formatting your clinical questions using this exact formula, like for instance, in ICU patients, does chlorhexidine compared to iodine reduce infection rates within 48 hours? You can rapidly and precisely search medical databases to pull up the most relevant, high-quality evidence. It saves you a ton of time, and more importantly, it totally elevates your patient care. Next up, Section 4, professional ethics and principles. Our practice isn't just governed by science and data. It is deeply, deeply rooted in core ethical principles that impact your daily interactions. When we look at the elements of the Code of Ethics for Nurses, we see clear mandates to practice with respect and compassion, and to make the patient our primary commitment. In vascular access, these are just abstract ideas. They are very tangible. Autonomy, for example, is the right of the patient to make independent decisions. That means they can absolutely refuse a line placement or needle stick at any time. And you know what? We must respect that. Then there's beneficence, which is our fundamental obligation to just do no harm, and veracity, which is our absolute obligation to tell the truth about all the risks of a procedure before we even begin. These aren't suggestions, they are rigid professional requirements. And those ethical principles we just talked about, they manifest physically in the mandatory timeout procedure. Before any invasive procedure begins, the entire team must literally pause. You verify patient identification and confirm that a signed informed consent has been obtained. Informed consent is a massive ethical and legal barrier. It requires that the consent is freely given, that the patient fully comprehends the risks, benefits, and alternatives, and that the whole thing is perfectly documented in real time. The only standard exception here is implied or emergent consent, where a delay in a life-threatening situation would cause immediate harm. But otherwise, no consent, absolutely no procedure, period. All right, bringing it home with Section 5, legal and regulatory considerations. Let's zoom out a bit and compare two massively important federal agencies, the FDA and OSHA. They have totally distinct but incredibly complementary roles in our hospitals. So the Food and Drug Administration, or FDA, focuses squarely on the patient. Through things like the Safe Medical Device Act and MedWatch reporting, they ensure that the catheters and pumps we use don't cause serious illness or death. On the other side of the coin, the Occupational Safety and Health Administration, OSHA, focuses entirely on you, the employee. Through the Needle Stick Safety and Prevention Act and the Bloodborne Pathogens Rule, OSHA mandates engineered safety devices to protect healthcare workers from occupational hazards. Simply put, one protects the receiver of care, while the other protects the provider. Looking a little closer at the FDA, they actually classify all medical equipment by risk level. Class 1 devices pose the lowest risk of harm. Think of your basic IV poles. Class 2 devices carry a moderate risk. This is where you'll find the bulk of our everyday tools, like peripheral catheters and guide wires. And then Class 3 devices pose the greatest risk, like cardiac pacemakers, which require rigorous pre-market approval. But listen closely, because here is what you absolutely must take away from this slide. The FDA requires instructions for use, or IFUs, for all of these devices. If you fail to follow the manufacturer's exact IFU, not only can that lead to unsafe care and patient injury, but it leaves you completely legally vulnerable to claims of negligence and breach of duty. Wow, we have covered an immense amount of ground today. We took you from the novice level of scrubbing a hub for 5 seconds all the way to a truly advanced understanding of federal regulations, epidemiological research, and ethical autonomy. So as we wrap up, I want to leave you with this provocative thought. How will you apply this comprehensive framework, from the basic mechanics of addressing change to the rigorous demands of evidence-based research, to elevate your very next patient encounter? Don't just let this knowledge sit in a notebook gathering dust. Integrate this masterclass into your critical thinking today and step into the role of a truly advanced, legally sound, and profoundly ethical clinician. Thank you so much for joining me on this explainer. Keep up the great work out there.